Hello everyone, one, two, three. So today we are going to discuss about my life. Oh my god, my mic is not working. I'll charge it. Solve the first question, guys. Just be quick and quick. The first question says a 45-year-old man with mild learning difficulties are known as a known genetic syndrome has been noted by his family to be developing problems with his memory and communication. He is seen in memory clinic and is diagnosed with Alzheimer's dementia. What genetic syndrome is most likely to be linked to Alzheimer's dementia? Is it Down syndrome, tuberous sclerosis, Prader-Willi syndrome, Leishman syndrome, Fragile X syndrome? So Alzheimer's is mostly associated with Down syndrome. What is basically a Down syndrome? Down syndrome is the most common cause of mental disability and affects. Am I live first of all? Yeah. Okay. Down syndrome is the most common cause of mental disability and affects approximately 1 in 1000 live births. The incidence 1 in 1000, 1 in 1000 live births you can find out a Down syndrome patient is such common. It is the cause of mental disability and affects approximately 1 in 1000 people, 1000 births. The incidence of giving birth to a child with Down syndrome rises with advancing maternal age at the time of conception. Approximately 94% of cases of Down syndrome are caused by trisomy of 21, 3.5% by translocation, and 2.5% by mosaicism. Down syndrome is significantly associated with Alzheimer's disease, both clinically and on neuropathological findings. Autopsy studies have shown neuropathology in virtually all brains of adults over the age of 40 years with Down syndrome, similar to that found in the brains of people who develop Alzheimer's dementia. So basically, Alzheimer's is significantly associated with Down syndrome, both clinically and neuropathological findings. When doctors have taken out the autopsy and studied, then they found that neuropathology in all brains of adults over the age of 40 years with Down syndrome is similar to that of people who develop Down syndrome. So over the age of 40 in the Down syndrome patients, they have Alzheimer's. Well, coming to the next question, a 33-year-old Paris woman is 2 days postpartum having delivered a normal baby boy. She has become increasingly anxious and has told the midwife she thinks the baby is changing. Careful evaluation fails to verify other bizarre beliefs, and she is continuing to care for the baby. Which one of the feature below is most likely to reassure you that the patient is not psychotic? Absence of auditory hallucinations. Patient does not believe the thoughts to be hers. The patient has symptoms of anxiety. The patient says that thoughts are stupid and tries not to think them. The phenomenon is intermittent. So the best option is option D. The patient says the thoughts are stupid and tries not to think them. Because here the patient have the presence of so-called insight. So here this shows the patient has insight into her own obsessive thoughts. She accepts they are her own lie arising internally. but realizes they are unlikely to be true, are unwanted, and tries to resist them. One of the markers of psychosis is delusional beliefs that are held with certainty, so not resisted, and the patient lacks insight into the false nature. It's important to distinguish obsession from psychotic phenomena, as the risk to the mother and baby is far greater with later. Next question: a 85-year-old woman who recently moved to a nursing home complains of feeling lonely, not sleeping well, and loss of her appetite. Over the past months, you suspect she is suffering from depression. She has declined psychological interventions. What would be the preferred treatment of choice? See, the best treatment what you have to give is about you have to give serotonin. So selective serotonin reuptake inhibitors. Serotonin is responsible for mood, sleep, appetite, food. So serotonin is responsible for it. So the first line treatment of depression in the elderly is a SSRI antidepressant. The elderly are more prone to the toxic effects of all medications. However, SSRIs have a better side effect profile than tricyclic antidepressants, monoamine oxidase inhibitors. The main side effects of SSRIs are GR bleeding and hyponatremia. Like all medications, a patient's medical history and comorbidities should be taken to be consideration while prescribing. In the elderly, cardiovascular disease, something commonly needs to be considered. Newer SSRIs such as sertraline have fewer cardiotoxic effects, while tricyclic as amitriptyline and imipramine should be avoided because of their cardiotoxic nature. The best is sertraline, so you can prescribe the patient sertraline. A 25-year-old male person complaining about becoming blind. There's no other past medical history other than episodes of breathlessness when he was a teenager. He was recently been made redundant from his job, and it appears that he is also in the midst of a custody dispute for his children. Medical neurological examinations normal. He has no obvious evidence of mental illness. His pupils react normally to light and accompaniment. It means he is not blind. So the answer for this is conversion disorder, in which to get rid of the stressful situation, people get this kind of perceptions. This mental disorder has no known physiological cause. Although the symptoms resemble neurological disorder, symptoms include blindness, deafness, loss of feeling, loss of muscle power. Possible psychological explanations of disorientation with conversion disorder include conflicting views, avoiding unpleasant activities, and seeking sympathy and support. The symptoms are real organic illness and appear not to be a temporary state of illness. In many cases, the symptoms may reappear even after proper medical intervention. If the environmental factors causing the illness are not eliminated, behavioral therapy is recommended in most cases. A 24-year-old female patient is brought to see you by her husband as she is preoccupied and has refused to go outside for the last month, stating that she is afraid of catching avian flu and that she knows that is likely because of all migrating birds outside her home. Okay, so it is her husband's socks on the washing line that can save her or have alerted her to this, as the order in which they are arranged determines a signal transmitted to scare the birds away. Her past medical history is unremarkable. She drinks only 4 glasses of wine per week and is a not smoker. She admits to marijuana use during her teenage years. Hemoglobin is normal range 130 gram per liter. White cell count is normal, more than 4,000 and between less than or 1,000. Platelets are absolutely normal. Sodium is normal. Potassium is normal, 4.5 millimoles, which is between 3.5 to 5. Creatinine is normal, less than 120 micromole per liter. Alanine ALT, alanine aminotransferase, is slightly elevated, 35 international per liter. TSH is 1.2 micro unit per liter. What is the most likely diagnosis? So she thinks that the birds are there outside her home. They can spread the avian flu. She's afraid of catching avian flu. So this is basically schizophrenia, and the type is acute paranoid schizophrenia. This woman displays symptoms typical to acute schizophrenia with elaborate delusions around avian flu and false interpretation of normal perception, arrangement of socks on the washing line. This is coupled with her bizarre assertion that the socks are submitting a signal to ward off the birds. Onset of acute schizophrenia is calmness below the age of 25 years, and abrupt onset with florid symptoms such as these tends to be associated with better prognosis. There is some assertion that risk may be increased in previous uses of marijuana. Atypical antipsychotics are compared with traditional agents and now being the drug of choice for managing conditions. Following a severe stroke, a 52-year-old man complains difficulty in remembering events occurred prior to this stroke but appears unable to form new long-term memories. On neuropsychological testing, he is able to perform tasks such as solving puzzles, visual discriminations, skin, eye, hand coordination movements. However, he is unable to consolidate any new information for immediate explicit recall. What would the most appropriate description of his present condition? So here in this case, the patient is unable to consider any new information. So he is basically amnesia, forgetting things, and he complains of difficulty remembering events, people's names, and even daily activities. He can remember events that occur prior to his stroke. So he know the things prior to the stroke, but he forgotten after the stroke. Okay, so prior to stroke he remembered but appear unable to form new long-term memories. But this one he forgot. After the stroke he forgot. After stroke he forgot the things. This is called anterogate amnesia, failure to acquire and consolidate new information after trauma. Example: severe disease, injury, surgery, or malnutrition is called anterogate amnesia. Although other cognitive abilities remain intact, the patient cannot cope with daily life without helping. This is owing to a major cognitive failure to store immediate learning experiences for long-term memory. This patient language skills do not seem to be affected since he can carry on a conversation with general events, although he can recall them afterwards. The patient can also count backwards and forwards. Such patients tend to require constant care and supervision. Interrogate amnesia. A 47-year-old female attends a substance misuse clinic for ongoing support following successfully completing a detoxification program and is ordered to prescribe naltrexone. Naltrexone is prescribed. It is for opioids. So naltrexone can use to relieve, prevent relapse in the treatment of which drug dependency. That is opioid drug dependency. The correct answer is opioid. Opioid is the correct answer. Opioid is the antidote for naltrexone is the antidote for opioid. Naltrexone is a long-acting opioid antagonist which can be used as an adjunct to psychosocial treatments to prevent relapse in detoxified patients who were formerly dependent on opioids. Naltrexone should only be initiated in specialist clinics. Patients should have remained opioid-free for at least 7 to 10 days before naltrexone is started. Naltrexone has also been shown to be useful for relapse prevention in those who misuse alcohol. 7 to 10 days before naltrexone serum should have remained opioid free. Naltrexone has also been shown to be useful for relapse prevention those who misuse alcohol. Psychosocial treatments used in opioid dependence include couple and family interventions, motivational interviewing, cognitive behavioral therapy called CBT, self-help groups, and psychotherapy. So for opioid we use the antidote called naltrexone. A 75-year-old lady admitted with confusion and urinary tract infection is convinced on appropriate antibiotics. You are called to see her during the night because of her severe agitation. She is trying to get out of bed and is significant risk of falling. You review her notes and find she has a history of Parkinson's disease and hypertension. Her blood pressure is 122 upon 82 with the pulse 88 and regular. Her temperature 38.8 degrees Celsius. She refuses further examination. What treatment should you prescribe? So it is a case of Parkinson's, so you have to prescribe lorazepam. In the context of Parkinson's, haloperidol is not advised, but lorazepam is endorsed by NICE guidelines as an alternative. It should be used at the lowest dose possible with a dose of 0.5 mg, the suggested starting level. 0.5 mg. Okay, so the drug which gives is lorazepam. Haloperidol is not recommended, and you should start with the lowest dose possible. A 45-year-old man presents to his GP with a feeling of low mood and a lack of enjoyment in life for the past 4 months. He has no history of previous low mood. When asked about recent life events, he describes in great detail the failure of a project to work. Despite this setback, he has recently been promoted and had a successful annual appraisal. What form of psychological therapy may be benefited for this patient? Interpersonal therapy, psychodynamic psychotherapy, cognitive behavioral therapy, cognitive analytic therapy, dialectic behavioral therapy. Since he is not able to cope up with the previous past situation in which he has fell into a project, then like has not performed the project well, then cognitive behavioral therapy should be given to deal to teach him how to deal with situations. The beginning describes a form of cognitive distortion called selective attention, which is common in depression. Patients attend to negative events much more than other positive neutral events, and within the CBT model of depression, this contributes to low mood. CBT, cognitive behavioral therapy, focuses on addressing cognitive distortions. Alongside behavioral therapy, there is strong evidence based supporting CBT is recommended by NICE, and access to CBT has been widened by the National IAPT Service. Next, a patient with schizophrenia is started on haloperidol, but 1 week later he complains of a feeling of restlessness and inability to sit still since starting this medication. So, inability to sit silently still is called akathisia. Akathisia. Okay, akathisia. The patient's symptoms are an example of an extrapyramidal side effect that often occurs with the older typical antipsychotics such as haloperidol and chlorpromazine. There are four types of EPS: extrapyramidal side effect, akathisia, dystonias, Parkinsonism, and tardive dyskinesias. Akathisia is the most common type. Presents as motor restlessness with an unpleasant, compelling urge to move and inability to sit still. Example: foot stamping when seated, constant crossing and uncross of legs or pacing up and down. It is important not to mistake akathisia for psychotic agitation, as the treatment of akathisia is to reduce the antipsychotic dose. Any further increase in dose is likely to make the symptoms worse. Although akathisia usually occurs in first 2 weeks of taking a neuroleptic drug, it may also begin after several months treatment. 57-year-old woman with a history of Downs presents to the memory clinic with increasing short-term memory loss and inability to hold down her job in McDonald's due to cognitive impairment. She was worked she has worked there for over 9 years, successfully taking orders at the drive-through. On examination, her MMSC, meaning mental status examination score, is 23 upon 30. There is no focal neurological deficit. Blood pressure 142 upon 82, pulse is 78 and regular. Heart sounds normal, just as clear. Her BMI is 27. Which form of cognitive impairment is she most likely to have? She is most likely to have Alzheimer's. Patients with because she is with Down syndrome suffers from accelerated Alzheimer's disease, and given there are no obvious fixed factors of vascular dementia, this is most likely answer. There may be some short-term benefit from cholinesterase inhibitors. Actual progression for dementia is likely. A previously convicted criminal now spends time working in a local nursing home and had recently joined the firefighting service. But defense was most strongly satisfied this behavior. This is undoing. This refers to the performance of an act that symbolically reverse some previous behavior or thoughts. The defense mechanism is commonly present who feel the conscious unconscious guilt. The other types of defense mechanism listed there is dislocation, dissociation, compensation, rationalism, and denial do not apply to this person. A 20-year-old male attends a clinic along with his mother, who is concerned that he has recently lost a significant amount of weight, appears to be exercising excessively. Patient refers to the fact that he hates how fat he is but does not feel he is over exercising. His primary concern when you speak to him alone that he has been having issues with impotency. On examination has a BMI of 17. This is called anorexia nervosa. Anorexia nervosa. Anorexia nervosa. Okay. This describes an eating disorder where individual induce weight loss of more than 15% of normal weight, resulting in BMI less than 17.5, and when individuals hold an overvalued idea that fatness is a dreadful state and will not allow their weight to rise above a very low threshold. Epidemiological studies of anorexia nervosa have demonstrated a marked dominance of females over males. Just a moment. Okay, so anorexia nervosa. This describes an eating disorder where individuals induce weight loss of more than 15% of normal weight, resulting in BMI less than 17.5, and where individuals hold an overvalued idea that fatness is a dreadful state and will not allow their weight to increase above a very low threshold. Epidemiological studies of anorexia nervosa demonstrate the phenomena is more in females and than in males, but it is becoming better recognized and diagnosed in males. Other epidemiological factors showing anorexia nervosa include a peak age of onset of 15 years, an increased incidence in higher socioeconomic groups, increased incidence of westernized countries. It seems that culture rather than race is important, as there is high incidence in second generation Asian girls and increased incidence in high risk professions, models, ballet dancers, and jockeys. Peak age of onset is 15 years. What happens in anorexia nervosa? The patient constantly exercises and reduces their uh, appetite, diet intake basically. Because of that, there is a significant weight loss, and the person gets less than BMI of 17.5, which is not all healthy for them. This can reduce the immunity. A 34-year-old man presents to the emergency department complaining that he has an electrical chip inserted in his head, which is giving him great power and sending him messages that I'm the one. He also claims that his legs are moved by the great force. These experiences began about 9 months ago, but only became troubling in the past few days. He appears slightly perplexed and concerned, however, he settled and sits quietly in casualty while awaiting further assessment. What is the most likely underlying diagnosis? Bipolar disorder, Cotard syndrome with drug-induced psychosis, organic psychotic disorder, schizophrenia, where he feels someone is controlling him. Schizophrenia patient describes several of the so-called first-rank symptoms of schizophrenia, the auditory hallucinations, thoughts being spoken aloud, voices commenting or discussing the individual in third person. The voice keeps saying he's a story. No, this is just includes second person auditory hallucinations. So it's like the person hears about himself from the third person. Someone is talking about him. Delusions of thought possession, thought withdrawal. The aliens are training my thoughts with the rays, thought insertion, as with this patient, thought broadcasting. The neighbors can hear what I'm thinking due to special transmitter in my head, thought blocking. So it's like the patient says thought withdrawal. The aliens are training my thoughts with the rays. Through insertion, as was in this patient, there's a heart chip in my brain. Someone's controlling my thoughts, my behavior, my energy. Okay, thought broadcasting is neighbors can hear what I'm thinking with a special transmitter in my head. The neighbors can hear whatever I'm thinking. Passivity experiences made actions, feelings, or impulses. The aliens made me feel sad and cry by shining the rays of the machine on my head. A delusional perception, attaching a delusion meaning to a normal percept. I saw the car and I knew I was the chosen one. A 20-year-old woman is brought to the emergency department with multiple cut wounds or to both her forearms, in which she admits that the wounds were self-inflicted because of auditory hallucinations telling her that she is worthless and deserves to die. She has a diagnosis of depression and is well known to the local mental health team for multiple previous suicide attempts. She is unemployed and lives alone in her home. She was previously tried on fluoxetine and citalopram without any improvement. She is transferred to the psychiatric unit for observation. She still harbors suicidal thoughts and refuses to eat and drink. Okay, so most appropriate treatment for her is she is not controlled by medications. Give her ECT. ECT stands for electroconvulsive therapy. Electroconvulsive therapy. This woman has depression with psychotic features that are not threatening to her life. She requires an intervention that can rapidly control her symptoms. The major indication for ECT is have severe depression with the life-threatening features. She has suicidal intent and refusal to eat and drink. There is an effective treatment modality for the majority of patients with depression psychotic features. In contrast to other options, improvement in symptoms following ECT begins within days, making the most appropriate option. A 25-year woman presented complaining of various physical symptoms. These have included low back pain, muscle aches, reflex esophagitis, irritable bowel syndromes during the course of the past 2 years. She denies any other symptom and physical examination is entirely normal. So the woman is 25 years old. She has a complaint of physical symptoms: low back pain, muscle aches, reflex esophagitis, irritable bowel syndrome for the past 2 years. So here the person is absolutely normal, but because of the psychological factors, she is getting these things in the form of pain. This is because the past trauma, which couldn't come out, and this is coming out in the form of pain. So this is basically a somatization disorder, somatic disorder. It's a somatic disorder, guys. This is a somatic disorder. Explanation: somatization disorder is characterized by multiple changing physical symptoms. Most patients have had multiple contacts with primary and specialist health services. WHO International Classification of Disease 10th Division requires the presence of 2 or more years of multiple and variable complaints, persistent refusal to accept the advice of several doctors, impairment of functioning owing to the symptoms, and resultant behavior. A man with a dubious record of compliance with HMRC regulations faces a tax audit. He begins to speak out welfare benefit cheats and people who do not pay their share to cost to society. What is the difference mechanism he utilized here? What is projection? Actually, here the patient is dubious record of compliance with HMRC regulation faces a tax audit. They speak about welfare benefit cheats and people who do not pay their share of cost to society. Projection is a difference mechanism whereby an individual attributes an uncomfortable or immoral act, example stealing, to other people as a means of diverting the attention away from themselves. Also, in order to alleviate the pressure of feelings of guilty, wanting to believe that everybody else is similar, whereby an individual attributes an uncomfortable act, example stealing, to other poor people as a means of diverting this attention away from themselves. In order to alleviate the pressure of feelings of guilt by wanting to believe that everybody else is similar. A lady loses her husband in a traumatic road traffic collision. 3 months afterwards, she says she regularly hears his voice when alone at home. She is not eating very well, has lost 5 kg of weight in this time, and she never sleeps after 4:30 a.m. in the morning. She has lost interest in all previously normal activities and does not find pleasure in hobbies or pastimes anymore. She says she often feels his presence around her and sometimes sees him when she goes outside. She is reassured by these feelings. Diagnosis should be suspected. The patient is actually getting psychotic. She is having depression because she lost her interest in normal activities, no pleasure in her hobbies. Vision or artery hallucinations and feeling the presence of person who is dead are all features of a normal bereavement reaction. The early morning waking, loss of interest in activities, and weightless hour fit a perfect picture of significant depression, which rights us to make this likely diagnosis in the early morning waking and weight loss. But absent this, fit much better with normal bereavement. So we are live since half an hour. Okay, so a 20-year-old man is there. He has learning disability. He noted is noted on examination to have short stature, morbidity, obese. Carers report that he eats excessively at all the time. He just eating, and this syndrome is most likely cause for the patient's symptoms. What syndrome is most likely cause for this patient symptoms? This is basically Prader-Willi syndrome. Okay, so in this is a rare condition. It is an estimated prevalence 1.2 to 1.3 per 10,000 people. Cytogenetic test can detect a deletion on chromosome 15, Q11 and 13. Q11 to 13, approximately 50 to 70% of cases. This syndrome is characterized by neonatal hypotonia, intellectual disability, short stature, obesity, and hip autism. Majority of the affected children have a mild to moderate degree of intellectual disability, usually between ages of 1 and 4 years. They gradually develop hyperphagia, which eventually leads to gross obesity. These children These children also manifest developmental delay and limited sexual function due to hypogenitalism. Abnormal secondary sex characteristics, micropenis, acrotocolism, moles, and amenorrhea in females are common. This is a feature. The Prader-Willi syndrome includes small hands and feet, cleft palate, and almond-shaped eyes, incurved feet, club foot, congenital hip dislocation, scoliosis, numbness in knee and ankle joint, and squint. Systemic abnormalities include diabetes, bowel obstruction, asthma, duodenal ulcerative collapse, heart disease, pulmonary boils, deafness, renal stones caused from hypothermia. Those with Prader-Willi syndrome can manifest severe behavioral associated with hyperphagia and self-injurious behavior, particularly in the form of incessant spot picking and temper tantrums. Characterized by neonatal hypotonia, disability, short stature, obesity, and cryptocolism. 17-year-old woman with the diagnosis of Prader-Willi syndrome comes to the clinic with his parents. He is holding down part-time employment a local warehouse but is beginning to gain weight rapidly, and he and his parents are concerned about proceeding where his BMI is elevated 36. Initial intervention, limited access to food. Although patients with Prader-Willi may achieve a relatively high level of function, able to hold down simple part-time employment, they still find it impossible to control appetite when presented with access to food. As such, the best way to limit weight by limiting access to food. 52-year-old woman is reviewed on the ward prior to discharging after 3-day admission for alcohol detoxification. She is requesting discharge, and this is her third admission over the past 2 years, and she would like medication to reduce alcohol craving that she had. Which of the following is the potential option in this regard? Naltrexone is a partial opioid antagonist and does have value in reducing alcohol cravings in patients with the alcohol dependence syndrome. It is, however, no substitute to CBT. Alcoholics Anonymous and must be used in combination with this intervention, supervision of a psychiatrist.